Can you guys hear me okay?
Yeah.
Yes, we can hear you.
Awesome. All right. Sorry for the delay. I'm staffing today. So, all right. So we're going to do part 3 of the EKG talk. In the parts 1, we kind of went through the general approach and how to even just establish the EKG and understand how to look at it and why certain things make sense and why some might not. And then we looked at, in part 2, we started with the PQRS-T. We stopped at QT. We got through most of the QRS complex going into like the fractionated QRS complexes, as well as AV blocks at that time. So now we are going to go into part 3, which is going to be QT, and then I should be able to get into the ST segments. And then I think for part 4, we'll go into the specific EKGs that you should know, the certain patterns, as well as ones that are specific to African Americans. So let's go into the QT interval. Again, just remember that when you're measuring the QT, what we really care about is a QTC, which is going to be calculated by the computer. It's not something that I even put the formula in here because it's really not necessary to memorize that. But just know that it starts at that QRS complex and then it's at the end of the T complex. The easy way, like a very quick way, is this one that's highlighted in like the peach color. If the T wave ends beyond that halfway point between your R to R interval, then you can pretty much assume, or if it's even close to the halfway point, then it's probably going to be prolonged. And then you can look at the computer to see what the computer says. Just remember, if there's PVCs or even atrial fibrillation, it's going to be very hard for the computer to accurately measure a QTC on there. But there's another method which I went into last year, and I'm going to go over to again, which is a little more specific that you guys can also use. So this is going to be on page 37 and 53 of your handout. So we're going to go step by step. I modified this because last year I just had it all on one slide and I think it was kind of confusing. So I wanted to make it a little easier. So let's look at lead 5 here. And what we're going to do is step by step, we'll see that first we're going to add a vertical line where that QRS complex starts. All right, so that first vertical line will go at the start of the QRX. Then we're going to create an angled line where we see the steepest part of the T wave slope. So if I were to just go down to V6, you can see that right here is the steepest part. So you're going to draw a vertical line right through that. So now we have an initial vertical, or a horizontal, I should say. We have a vertical line at the QRS, and then we have a slanting horizontal such line at the angle that is the steepest on the QRS. And then we'll create a pure horizontal line to represent the isoelectric. I think this is probably the harder one to do because a lot of patients have like a wandering baseline, it seems, based on their respiratory pattern, but just kind of look at the QRS and the P waves that they have them to create an isoelectric line. So you can see here, we've made a vertical, we made that horizontal slanting, and then a pure horizontal. So now we have 3 lines. And the intersection of where the horizontal and that angled line occur is what's going to allow you to make now a true second vertical line. And that's going to be important because when we look at the 2 vertical lines, then those are going to be what we actually do our measurement between. And in this situation for V5, we can see that there's about 3 large boxes easily between those 2 lines. And if each one of those is 200 milliseconds, that puts us already at 600 milliseconds, but if we do it, specifically by measuring the small ones, in this example, it came out to be 740 milliseconds, which we know in general, most patients, if I go back to that previous slide, you want it to be at least, I think I'm on the next slide actually, but you should see it, but less than like 450 or so. And it depends on the gender as well. But in this one, it's clearly going to be a prolonged. So less than 440, 450 is kind of for the corrected is what we start looking at. But again, it's going to be age and gender dependent, not age, but gender dependent. Prolongation can happen by a lot of different medications. QT, I think it's QT hyphenated drugs, if not qtdrugs.com, has a long list. I think there's archives as well that are maintained by both UpToDate and Dynamed as well on those. But just know that almost every medication can cause this, as well as the inherited conditions. I did a rundown on congenital long QT syndrome last year. I'll see if I can do another one at some point this year. Just going over those. But if you guys recall, history of syncope should be one of those things that you should always consider. We do an EKG because we're worried about arrhythmias in general. We just use that term. But a lot of it is looking at the QT interval. I've caught it only once before, and it was in a young soldier. She was having syncopal episodes and lightheadedness, and she ended up having congenital long QT syndrome. And then they ended up putting her on a beta blocker, and I think she ended up having to be sent out of the military because it's just a high risk. But just know that condition exists. So if patients have single episodes, but it's not stress related, it's not someone that's been outside in a hot weather for a long period of time, and they have a QTC that's greater than 450, especially with a family history, it pretty much nails the diagnosis right there. This is an example here where you can see that the QT at the very end of where it marks, you can see that it's pretty much at that halfway point between the R to R. So this would be an example where that it appears to be prolonged, but if you want to do the more specific method, which we talked about here, then you can do that as well as looking at the computer's output. So here's an example, of the QT where, again, it doesn't look like it's prolonged. You can see it's kind of slurring up, but if we were to take a line here, we'd put the steepest part. So the steepest in this example, I'll go to V5 because that's what we did last time. It's not here, right? It's going to be the downslope going in this direction. So if I can draw, let me see if it's going to allow me to draw on this. So if we have a draw line here, clearly it's not straight. We had a line here for the QRS, but if I were to do the way that I was supposed to, there's a horizontal and then an isoelectric. So then what you're looking, wow, I don't have a mouse pad, so that's why it's completely off. If you do this line from here to there, then you can measure that out. And remember, one box is gonna be 200 milliseconds. We said 450s are cut off. So once you get to 2.5 boxes, you already know that it's going to the direction of being somewhat prolonged. Let me erase all that and then get off this. Okay. So let's look, any questions on the QT segment specifically?
Are there any times that you keep running into where the measured from the machine is completely different? I mean, I know you need to know how to do it, but have you seen that in one particular instance repetitively?
I think the most common times I see it is when there's intermittent PVCs, or if there's, I don't want to say intermittent, like where there's just one in a 12-second strip, but if you have maybe someone that's in a bigeminy or trigeminy where there's enough on there that it's going to throw off the computer. So that might be a consistent time where you see with PVCs, or if they have atrial fibrillation at baseline, or I should say if they have I have a patient, there's a patient wandering back here. Or if you have someone who has like a low voltage or even hyperkalemia, where if a combination of low voltage with hyperkalemia, then the QRS and the T waves are going to be kind of hard for the computer to distinguish. So then it's going to be monitoring or measuring from the wrong thing, where if it measures the QRS as being the previous T wave because it was so high, and then it measures to the next T wave because the QRSs are dulled from the low voltage, then you'll see a strip or a QTC that's crazy long. So that's why, like you mentioned, Dr. Long, that it is important to be able to measure on your own, but even just looking at the EKG, because that computer is definitely going to be fooled multiple times. So hopefully that answers your question.
Thanks.
Yep. All right, so let's look at the ST segment. This is the one that I think is probably one of the larger segments of this talk, because there's so much pathology that we have to know of, as well as benign conditions that occur at the ST segment. We know that it's from the end of that QRX to the beginning of the T wave. So it's going to be the depolarization we talked about with commota cordis, I think either last time or in part one. You had that fastball that goes into the catcher's chest, can induce a VFib. So that's also a reason why we do synchronization with our cardioversion as well. We know that depressions versus elevations can indicate specific pathology, whether it's infarction or ongoing ischemia. So it can have clear repercussions or implications, for patients when we're treating them. And there's so many causes, whether it's pure ones that are going to tighten our sphincter, like ACS, maybe some left bundle branch block, Takotsubo, that doesn't really concern me that as much, but coronary vasospasm, pericarditis, things we see all the time, benign early repolarization. I have a few slides on that because it is probably the more, I don't want it becomes like our fibromyalgia of our ST segments, where if we don't know what's going on, we're like, oh, it's probably just J point elevation, or maybe it's just benign early repolarization, but we shouldn't jump to it. It's clearly a rule out, right? And then I'll talk about Brugada because the boards do like to talk about it. You're probably going to have at most one question just on Brugada. That's pretty much localized to the cardiologist and their specific boards. And just know if you're Takotsubo, almost always it's going to be a female who had a recent death in the family, and then they're coming with chest pain. But you have to do everything, right? So these aren't patients where in the ER you're saying, oh, this is Takotsubo. I don't need to actually do anything about it. You're going to treat them with drip, heparin drip, everything up until they get that cath, until that cath shows completely clean coronaries. You should treat them for ACS. So just remember, even though everything is pointing in the question stem to Takotsubo, still go through the entire management. So I divided this by elevations, then depressions, and then some of the benign variants. So we have the earlier polarization, which is a normal variant. It's going to be a concave up, which we'll go to. And you're going to see that the T waves are going to be very symmetric as well as being upright. Ischemic heart disease is going to be different. It's going to be convex up. So when you have concave up, and you're seeing more of the happy face, which I'll have some slides on, versus a convex where you have the tombstone appearance. That is very important to know. But you can have things that are a tombstone appearance, but it's still going to be a benign and early repolarization. So these aren't hard and fast rules, but they are something that can help you maybe at night when you're on your own for making a quick determination of how aggressive you want to be. I would say in almost every situation, you should be as aggressive as necessary. If you have any question, and you talk to the cardiologist, or it's the fellow the cardiologist overnight, and they say, well, or maybe you're not able to get a hold of them. In every instance, you should treat them as if it's ACS. No one's going to fault you for that. If you don't treat them as if it's ACS and it ends up being that's where there's going to be issues for it. So when in doubt, just treat for ACS. Acute pericarditis, you're going to see the concave up. So they're going to have that same benign polarization appearance with that happy face in almost every single lead, right? With usually the right clinical scenario. As I talked to or alluded to in one of my previous talks, we are seeing with COVID and coronavirus specifically, more patients having more myocarditis rather than pericarditis involvement. And remember, the major distinguishing factor is going to be that troponin leak that you're going to see. But just be aware that pericarditis is most commonly caused by viral conditions. And as a result, it should be Heiner differential in the right patient population coming in with the right exposure history as well. And then know the other things that can cause ST elevations or LVH, left bundle, and hyperkalemia, as I mentioned earlier, with our mimics for QT prolongation. So here's some things where it can be ACS, but the classic tombstone appearance here is what we kind of hope that we're going to always see because it's easier for us to distinguish. These are the types that you're going to see on your boards. Even this one, I think, is enough of a classic presentation. These are the ones that can fool you because it looks like it has that happy face. So when I say happy face, let me draw on here, and I have a slide later that kind of shows it. So bear with me with the mouse, but if you have the two eyes here and then you have that mouth with the happy face that's able to fit in there, those are the ones where it can fool you into thinking that it's a benign or early repolarization, but it's not. Even this one looks like it somewhat has it, but these are cases that were pure ACS. So again, when you're in doubt, you should always treat for ACS and get your cardiologist involved. Here, again, it has, and we'll start from left to right. We can see that the T wave, and we'll go over as well the progression, because we know there's a clear progression from a timeline of what happens with the T waves versus the ST segments and then inversion, et cetera. So I'll get to that. Just know that early peaked T waves are things that we get concerned about with ACS. It's not going to necessarily be an ST elevation that they're presenting very acutely. If you recall from the talk from Dr. Seeker on hyperkalemia that he gave just a few weeks ago, he mentioned that one of the providers came and talked to him thinking this is ACS. He said, no, this is hyperkalemia. Just give them some medications to try and lower it, and it seemed to help. But I think it was the right talk or the right concern in general is to make sure that they're not missing that, right? But I brought these in here because these STS segments can have all kinds of appearances, even Brugada type appearances, which we'll get to. And just know that if you have any suspicion, especially here, you can see the ST segment started to get some combination with a T wave as well. So that peaked T wave brought that segment up. But it's really important more, I would say, to know what the boards like to test you on, and because it's clinically relevant, this progression that you should see. Now, the difficult thing about the progression, I'll say, is when I'm developing these talks for you guys, I try and make sure that I don't go off one source when I get information such as this. I try and find multiple sources to make sure they're all corresponding to the right information. And I have seen some mixed information regarding what seems to happen first, and even with a timeline. So this is just one example. But if you find different references that show different information, that is completely possible because I've seen it. But this is one that I thought was the more consistent with what I found. And what they said was, first, you'll see this immediate elevation or a hyperacute T wave, tall, peaked. But here's the key, it's going to be symmetric. And that's what you really want to look for. That's the fact that it's symmetric should increase your suspicion for this being cardiac involvement and not maybe just pure hyperkalemia from maybe someone that has ESRD or really bad acute kidney injury. And then you're going to start seeing the elevation of the J point. So we can see at the 18-minute mark right here, the J point starts to elevate. I'm going to move my mouse away so you can actually see what I'm talking about. It continues to elevate even to the 24-minute mark, where now the ST segment and the T waves are going to start to merge even into the 28-minute mark. So again, these sections from 0 to 24 minutes, you might not see, especially if these are patients that are admitted, because it's probably going to take them maybe 10 minutes for the ambulance to get there. Then they're going to stabilize the patient. By the time they get to the ER, maybe you're lucky if it's at the 18-minute mark, but it's probably already going to be at this segment between 24 to 28. So for us as hospitalists or internists in the hospital, we might not see this until unless they're actually in the hospital and maybe they had a surgery, or myocardial injury after non-cardiac surgery or MENAs. Those kind of patients might be the ones that we see, but you should still know about it because the boards do like to test you on that. And then once you see these ST and T wave segments start to merge, then the T wave is going to start to drop. It's going to turn back to the baseline. A Q wave will develop, and then the T wave is going to invert. So let's summarize. We're going to see initially the T wave peak. It's going to be symmetric. It's going to bring the ST segment with it. So now you have ST segment elevation. As it brings it with it, you're going to see a merging of the ST segment and the T wave. Then the ST segment is going to drop, going back to the baseline. And as it drops back to the baseline, then you're going to see the Q wave concurrently develop, and then the T wave will invert. But you can see there's a long period of time between 1 hour and 3 weeks for this to occur, which is why it can be difficult when you see patients that had a recent coronary injury, whether they are intervened on, who present maybe 2 weeks later with recurrent chest pain. And one of the questions that they had a stent is this in-stent thrombosis, which I think I might be getting into. But in the end, always get the cardiologist involved and treat as aggressive as you can. And I got this, all those references for the most part from my talk are going to be at the bottom of the slide, so you know exactly what goes to what instead of at the end. Let's put a smile on. Yeah, sorry, I just saw that. Yep, exactly. So here's some other changes to the ST segment that we can see that might not be necessarily ischemic in etiology or true infarction. So pericarditis, remember that you're going to see some depression or ST or PR elevation in the AVR segment. You're going to see potentially some T wave symmetry as well, but it's going to be hard for you to tell unless you see pure ST segment elevation throughout and not in a specific coronary pattern, which we talked about on our last talk. That would increase your suspicion, especially in the right clinical scenario. A left bundle branch block with that deep S segment is going to be more suggestive of a left bundle branch block and not a true ST segment. But because there's ST segment elevation with left bundle branches, that's why it's very difficult to distinguish if this is true ACS, and why we've talked about, while it might be considered old back in like 2011 or so, not to, well, I think it was more 2012, 2013 from ACS or ACC, of saying, oh, if it's a new left bundle branch block, should we assume that it's ischemia? I think here at our hospital and in most hospitals, they'll say, when in doubt, if it's a new left bundle branch, treat as if it's a new ACS pattern. And then if you have an aneurysm, that can even cause ST elevation, as well as Brugada, which I'll talk about in a second. But that Brugada is very unique because it's going to have that sloping type appearance, that wind sail appearance, which is what's going to distinguish it from others. So again, the ST segment elevation that you see, like I talked to you about regarding your ability to distinguish it from pericarditis, is going to allow you to decide, is this true ACS or not, because it's going to follow a specific pattern. We talked about this ad nauseum, but just to review, V1, V2, and Dr. Duffy talked about it as well when he did his talk for ultrasound, is knowing that V2 is the septal, and the anterior is going to be more in 3 and 4, but it can still involve someone 1 and 2, just because we know the actual anatomy of the heart is kind of rotated, showing that right side more anteriorly. And then the lateral segments, your high lateral are going to be your 1 and AVL, which your low lateral will represent V5 and V6. And then leads 2, 3, and AVF are going to be your inferior leads, with the posterior MIs also being potentially involved with that. Remember, your RCA can sometimes supply that inferior or posterior portion of the heart, as well as the left-hand LAD can kind of loop under and then provide at the very distal segment some of the inferior part as well as the posterior portion of the heart. So just know those associations. And I put as this bullet because the boards do like to test you on posteriors. And I think it's because we just focus so much on V1 to, 5 and 6 and 2, 3 AVF as inferior MIs. We don't give a lot of love to the posterior infarcts, so it's very easy to forget about those or miss them. So just know you're going to look for ST segment elevation in the above lead, so 2, 3 AVF with reciprocal depression and in V1 and 3. So I had this image above, which is why I said C image above, but I put it actually here. So when you see that reciprocal ST depressions in V1 and 3, V1 through 3, as well as ST elevation in 2, 3, and AVF, that should automatically clue you in as this being a posterior infarct, okay? But if you see just 2, 3 AVF being involved and maybe some lateral involvement, but not ST depression in V1 through 3, that's not as common to be a posterior infarct. And what you're going to do, I think, so I had this next slide. When you're looking for the posterior MIs, so if you said you did an EKG, you look at the ST or 2, 3 AVF and you see some elevations, you're like, okay, I know there's ACS going involved. Is this an inferior infarct or a posterior infarct? Then the next thing you're going to do is look at V1 through 3 and you see ST depression. Then you might say, okay, now I need to do a posterior EKG. So not the same thing as right-sided, which we'll get to, but a posterior EKG. So what is that? You're going to take leads, you're going to take 2, 3, 4, and 5, or 4, 5, and 6, sorry. You're going to put them on 7, 8, and 9, or they're going to become 7, 8, and 9 on your left clavicle. So you're going to use that inferior angle of the clavicle or scapula, to mark V8, and then just a little lateral to that, more medial, or a lateral will be V7 and a little medial will be V9. And then when you do those, the posterior segments, what you'll see is this ended up becoming, well, I think I marked it. Yeah. So you'll see some elevation in 7, 8, and 9. So let's go and summarize it. Again, 2, 3 AVF, elevation, reciprocal depression will be seen in 1 through 3, which marks, okay, I need to be concerned about posterior infarct. You're going to take 4, 5, and 6, you're going to put those as 7, 8, and 9 on the inferior angle of the scapula on the left side of the patient. And then what you're going to be able to look at is find a new EKG. So this was the first EKG where we saw 2, 3 in AVF. We saw some elevation. And then we looked at V1 and 3. We saw reciprocal depressions in 1 and 3. So we said, okay, let's do a right-sided EKG, or a posterior EKG, sorry. When we did a posterior EKG and we put 4, 5, and 6 now on the back of the patient on that left side, what we saw is the elevation now shows up in 4, 5, and 6, which confirms a posterior infarct. Okay. So again, you know that heart is on the side, but these leads are going to better capture electrical activity coming from that posterior aspect of the heart, which is why you move them to that left side. And then you can see the clear elevation showing up on 7, 8, and 9. Make sure when you're doing these, you need to mark them. You need to write down 7, 8, and 9 so people know, especially the cardiologists, when they're flipping through the EKGs, they know exactly what they're looking at. But how does this differ from a right infarct? Because we know that there's multiple types of ACS elevate or episodes that occur. We know there's different types of elevations, infarctions in the ST segment. And I always talked about posterior infarct. So what about right ventricular infarctions? We're going to still see that inferior lead or 2, 3 AVF involvement, which is why the boards like to test you on it, because you just have to know that you can't use just elevations in 2, 3 and AVF as your marker of, oh, this must be a posterior infarct or this must be a right ventricular infarct. You have to do a little more than that. One of the clues that I found that I thought was helpful is when you see an ST, if you're looking at 2, 3 AVF, which we know is going to be inferior involvement, and we see that the ST segment is elevated larger in 3 than it is in 2, because remember, lead 3 is going to be more towards that R than lead 2 is when we're looking at our Einthoven's type triangle, then we know that this is potentially going to be something that's more suggestive of a right ventricular infarct, because remember, the electrical activity should be going down in this direction. But if it's going more towards lead 3, that means that electrical activity got pushed over and there's some infarct kind of going on here. So here I kind of zoomed in on this exact slide and tried to show you the distance. You can clearly see there's a distance change between leads 2 and leads 3. So if you see 2, 3 AVF elevation, we know it's an infarct, but we don't know if it's posterior or right ventricular infarct. If we had vital signs and we saw what kind of changes in our vital signs might be more suggestive of a right ventricular infarct before I continue on. Yeah, hypotension. So if you see that patient's blood pressure is dropping on you, you should immediately know, okay, I'm not going to give them nitroglycerin or anything that's going to be a vasodilator. So then you'd be pushing fluids for them. And then you might look and say, oh, okay, I'm noticing already that lead 2 versus, or lead 3 versus lead 2 show an elevation in the ST segment more. I'm thinking this might be everything's pointing towards right ventricular infarct. So what are you going to do? We're going to do a right-sided EKG. I don't know if I put a diagram. Oh, I didn't. Okay. Maybe I wanted to decrease my slide size because 237 was too much. So if I were to kind of go back to this, it's not the best one because the patient's back is to us, but we would do our regular, instead of having lead 1 on the right sternal border at that 3rd or 4th intercostal space, what we're going to do is put lead 1 on the left side, and then we're going to flip flop them. So then lead 2 is going to be on the right side. And then we're basically going down as a mirror image down the right side of the chest versus the left side. All right. So sorry, that'll be a mental note. I need to put a diagram for that. So when you're doing that right side EKG, then here on a right side EKG, we found that these were all, and when you're marking these, you should put V1R, V2R, V3R. So again, someone that's reading through this knows exactly what they're dealing with. But you can see that now there's some elevation that we're seeing in V3, 4, 5, and 6. So throughout, we're seeing some elevation. And then V1, we're seeing them depression because, again, we flopped those leads. So we're seeing that overall electrical activity is now kind of going in this direction. So now it's not going more towards V1, which was over here. So as a result, we're going to see some depression and more of a negative voltage pattern on that. So it kind of makes sense. We're still seeing the elevations in 2, 3, and AVF. We didn't change any of those around. The only ones that we changed was V3 through, or V1 through 6. And we saw is now that we're seeing that V4, 5, and 6 elevation, because again, if I go back to that diagram, those were going to be more towards that right side when we flopped the leads over. It's consistent with what we were concerned about. So again, just to summarize, because personally it helps me, I can't honestly pay attention for too long, to be honest with you. So I always have to summarize things, and maybe you guys would say, maybe you're not. But when it comes to the posterior infarcts, know that you have that 2, 3 AVF infarct pattern, but then we're going to see that there's going to be reciprocal depression in V1 through 3. And then when we see that reciprocal pattern, then we do the posterior imaging where we put the leads on the left side of that scapula. And when we did that, we saw ST elevations in 4, 5, and 6. But when we were concerned about a right ventricular infarction, maybe because the person also had some reciprocal hypotension going on, but we saw that same initial pattern of 2, 3 AVF being involved, but we saw 3 was higher than 2. We said, maybe this is a right ventricular pattern. And again, it's not always, but about 80% of the patients that are going to have an ST elevation show up in V4 specifically. And when we did that right-sided EKG, we saw that 2, 3, or 4, 5, and 6 had those elevations that we were concerned about. So that's kind of a summary of posterior and right-sided infarcts or right ventricular infarcts, because I think it's very board relevant and it's easy to mix them up. But if you can think of those associations, whether it's leads 2 and 3 and comparing the ST segments, or looking at 2, 3 AVF and seeing the reciprocal depression in V1 through 3, hopefully that helps you be able to distinguish the two. Again, when you're looking at ST, so any questions before I go on into true ischemic or other ischemic causes? Okay, so now let's look at this whole term of reciprocation. So as I've talked about with ST elevations and infarctions, if you had ST elevations in 2, 3 AVF, like we've been talking about, you should see some reciprocal changes somewhere else. And I honestly asked, someone might tell me something, but I always kind of verify it and try and figure out why is it that that is true. So I said, let me look into more about this reciprocal pattern and why it occurs. So you look for reciprocal ST depressions in the electrically opposite leads. Again, going back to our triangle and this Einthoven's direction, we're looking for the electrical opposite leads to show us why, to understand why those specific patterns happen. So let's take an example. If we saw elevations in the high lateral, which is 1 in AVL, it's typically going to produce a reciprocal ST depression in lead 3. So if we had infarctions down here, then the opposite is going to be in leads 3. So let's go back to here, AVL, high lateral, 1 in AVL, the electrical opposite, it's going to be in lead 3. Kind of cool, right? Not really, I know. So the reciprocity is not always going to be seen though with pericarditis or even early repull. So when you think about ST elevations and you're wondering, is this an infarct or ischemic or coronary vascular cause, or is this an inflammatory cause, or maybe just a benign variant? You're not going to see reciprocal changes or ST depressions. All right. So just if you remember this drawing that we went over on the first part of our EKG talk, it's going to allow you to find out where that reciprocal pattern should be seen. Here are some other elevations that I kind of put, or just showing you that if we had lead 3, which we talked about back here, and then we know that it's kind of pattern or brother or sister is going to be AVL. Then if we had ST elevation in lead 3, then, and this is an actual EKG, then we saw reciprocal changes in AVL with a depression. So it kind of fit cardiovascular cause. Here's a patient who this is from learntheheart.com. I think they work together with Life in the Fast Lane. So that's where I got these EKGs from. And if we saw ACS in a patient, ST segment elevations in leads V2 and V3, that tombstone type appearance, even going into V4, then we look for reciprocal changes, and we can see that there's some reciprocal changes even in leads 3 in AVF, as well as some in V6. So let's go back. So we talked about, well, V3, we can't really use that too much for this pattern because we didn't have AVL or 2-3 AVF involvement, but we saw that there were some at least reciprocal changes going on, whether it's in V6 or in 2-3 AVF. If this was a pericarditis picture, we're not going to see any of those reciprocal changes in these other leads. And an inferior infarct, so we just talked about that ad nauseum with right ventricular infarcts as well as our posterior infarcts. Here in 2-3 AVF, we can see some elevations going on. If you wanted to look for a specific right ventricular infarct, what pattern would we look at between leads 2 and 3? Or 3 and 4, or I mean 3 and 2 or 2 and 3? Exactly, Dr. Chaudhry. So greater elevation in the ST segment in lead 3 and 2. And then we look for ST depressions. And here I can see one in AVL and even in lead 1, which we know those pair up as the high lateral. So it makes sense for saying that it's consistent with that inferior infarct. And then if we looked at the posterior infarcts, which we talked about in that first part, here, it's kind of hard to see, honestly, the ST segment elevation maybe at the very last beat of the leads 3, kind of here in AVF as well, but we can see some reciprocal depressions in V1 and 2. So just, it can be hard to see, and these ones you might need to get that cardiologist involved if you haven't already at that point to kind of help you out. But again, always treat as if it's ACS, if not told otherwise. And if we did a posterior EKG on this patient, this is the same patient, where we saw that 2-3 AVF elevation. We saw with posterior EKGs, we're going to see, or concerns, we're going to see V1s through 3 or so, going to have some ST depression, which we see some kind of depression here. Maybe hard to see here, but you can see that baseline is actually higher than what you might initially think. So when we do a posterior EKG on that left scapula, and we're going to change 4, 5, and 6 over to 7, 8, and 9. And then when we change it over to 7, 8, and 9, now we can see the elevation show up. So it kind of confirmed our suspicion. This was supposed to be a quick quiz. The title didn't show up. So it's identify the location of the ischemia or infarction. So what are you guys seeing on this one? Where do you see the ST elevation? Inferior, yep. So in 2-3 AVF. And then where do you see some reciprocal changes? Yeah, in V1 and 2, I can see some depressions here. So based on that, what would your initial suspicion be? Is this a right ventricular infarct, or is this a posterior infarct, or neither? Right, since AVL is reciprocal. Absolutely, yeah. So it kind of fits. And if we did a 7, 8, and 9, we might see some elevations in those leads as well. So great job. So acute MI. And then in this one, what are you guys seeing here? Is the background noise too much? I can close the door. It is, okay, hold on a second. All right, sorry about that. Of course, Mafouz was the only one that felt that way. All right. So V1 and 2 or through 4, absolutely, we can see some elevations here. We don't see some reciprocal changes as well, though. But I see some elevation in AVR. Not much going on in 2 and 3. So LAD septal, absolutely. So this is more of a classic, elevation that we're concerned for in the anterolateral anteroseptal MI. What about here? What do you guys see? Someone says anteroseptal again, or maybe that's a old one. So deep in V3 and 6. Yeah, so we see some ST depressions in V3, 4, 5, and 6.
Posterior.
So why do you say posterior?
Because if you flip V2 upside down and look it into the light, it looks like an ST elevation. If you look at AVR, we also have some ST changes.
Mm-hmm. Absolutely. Yeah, so this is a posterior MI. Great job. So you see some depressions in 3 and 2. If we saw a better 2 and 3, elevation, we could use our rules that we were kind of talking about. But here we see that there's that depression there. So then just like you can use that V2 kind of rule that you had talked about. It sounded like, I think that was Dr. Long. Or you could also just do the 7, 8, and 9, then see that it's a posterior infarct. So great job on that. Any questions before I go into benign early repolarization? All right, no question. So what is it? What is benign early repol? It's early repolarization. That's a benign finding. Very eloquent, right? We don't really know why it happens though, which is interesting, but it's common, but we just don't know why. Very common in young athletes. Since I'm the CSU Pueblo team physician, I'm seeing this in our patients, but the times that it really concerns me is in the COVID era. If they had any exposure, we can see that, and it's not benign or early repol. It could be true damage that's happened to the heart secondary to COVID. So COVID's definitely thrown a curveball for multiple reasons. And so those in general, less than 50, it's not uncommon to see this. But how do you define it? It's when you see that J point elevation that's going to be greater than, so here's the J point right here, greater than 1 or equal to 1 millimeter or more, and 2 or more contiguous leads. You have to have them, again, contiguous, V1 and 2, leads 2 and 3, et cetera, or 2, 3, and AVF, which we just talked about. But we're more commonly going to see it in 2, 3 AVF as well as 1 in AVL or V5 and V6, so those lateral leads. You can look for notching in the QRS. So this is the notching that they're talking about that I thought was interesting, because we talked about that notching, that fragmentation that you might see on the initial upslope. But when you see it on and that might be suggestive of early cardiac disease, or maybe someone who already has cardiac disease that hasn't manifested already in clinical symptoms. But if you see on the downslope, this can be with slurring of that. So this is the slurring that they're talking about on this bottom one. And then the notchings here, that's again more consistent with benign early repol. But you're not going to see reciprocal changes in other leads, because this isn't an ACS event. This is not an ischemic or an infarction that's going on. So you're going to see it only in contiguous leads, multiple leads, but you're not going to see any of those reciprocal ST changes that we talked about. So know about this notch that you'll see in the downward segment, as well as the slurring, to increase your suspicion of this being benign early repol. This is the same exact image. I just put in a different slide and increase the size so it's easier to see, because it might not be the easiest over, slow internet connections or based on the monitor size. But again, we see this ST segment elevation. We know that we're going to monitor that 1 millimeter or more measurement to make that definition at the J point. And then we're going to look for that descending, if you want to call it the QRS, the little notching that occurs, as well as some slurring that can occur as well, as being some of those markers that we can be concerned about for making that diagnosis. So here's an example of early repol of the ST segment in an EKG. So we're looking at V leads to V2, V3, and even to V4. And you guys can see, where do you see the notching occur at? V3. Yep, yeah, so there's notching at V3. It's kind of more classic in the V4, but you're absolutely right. And then we see the slurring happen in V5 and 6. I don't see any reciprocal ST depressions anywhere. So it also increases or decreases your suspicion for this being ACS. Oh, I forgot I did the animations for you guys. Here's that put a smile on that face for Mathew. And here's an example. I think I did, I thought I did a zoom in, but again, we see some notching even in, yeah, it's happier now. V3, we saw the notch. We don't see it as much in V4, but we see the slurring occur in V4, and then the notch again appears kind of in V5. Now, trying to juxtaposition the two, here's ACS. So we don't, in ACS, we remember we talked about how you initially see the T wave kind of go up, it peaks, then it brings the ST segment with it. And then after the ST segment and the T waves merge, then the T wave starts to go down, it creates that Q wave, and then the ST segment drops back down to normal. So here we can see that the T wave is inverted, but the ST segment is still elevated. This is more of a sad tombstone face, right? So if we were to zoom in on that one, we can see that it creates that tombstone for us. So it's not a happy face. This is the type of pattern we get concerned about. We can see some depression here, as well as leads 2, and mass is really off, sorry, leads 3, and an AVF. So we see that depression that's reciprocating from leads, honestly, 2, 3, 4, not much in 5, but we see some changes to the ST segment in 5 and 6. So reciprocal changes, tombstone appearance, more consistent with ACS, not benign early repole. If you want to get really specific, this is a table that I included in last year's talk, and I just kind of included in here. You could look at the concavity versus convexity of the J point to figure it out. And what they said is if you draw a point, sorry, let me try it. Here we go. From the actual start of the J point, and you drew a line to the peak of the T wave and just put a line between the two, then you could see, this is really off. Let me turn off this pointer, sorry. I wonder if that's why it's, no, it's not. All right, let me use a notepad. Okay, that works better. So if we drew that line between the two segments, you can see there's a little gap here. So it's more suggestive of, yeah, the Undertaker. What was, Mathew, what was the Undertaker's finishing move called? That's right, the last ride. And it was barred because it was leading to cervical injuries and dislocations and herniations. So, but if you drew the line from, and the reason why he's bringing that up for the interns is because when I gave these talks in person, we would have a WWF, WWE theme for each quiz. So now I don't get a chance to do that. I used to do it to your brother. Okay. Yeah. Choke slam. But if you drew this line, what you could see is now that more of that ST segment is on the top part of that line. So maybe it's more suggestive of a non-concavity or a convexity, which is more concerning for that tombstone ACS type appearance. Can I move through these slides? There we go. I have to use the keyboard. So J point, we talked about the notching that we're more likely going to see as long with the slurring. You're not going to really see that with a STEMI. I'm not going to go into these EKG predictors. This is way too complex. That's really, in my opinion, not necessary from an internal medicine perspective. If you end up going into cardiology, then you'll probably have to memorize these things among others. But I think these are the most common things to look for, as well as cardiac biomarkers. You're really not going to see it. You know, if you think that this is benign early repole, but you don't know for sure, then you could get cardiac markers in those patients if you're maybe started them on medications before you find out. But clearly it's not going to be something that we're concerned about. And with the new advent of our early or high sensitivity troponin, we're probably going to still catch elevations in that faster in our STEMI patients. So ST depression, so that was a whole section just on ST segment elevation. So we went through benign early repole. We went through the different ACS type of presentations, the tombstone, last ride appearance versus our happy face appearance. We talked about right ventricular infarcts versus the posterior infarcts and utilizing 2, 3 ADVF as well as V1s, 2, and 3 to help us out. And then creating a new KG, whether it's 3, 4, and 5, you know, right side at 5, 6, and 7, or yeah, 7, 8, and 9 on the posterior side to kind of help us out from that. But now we're going to go into ST segment depressions. I would like to finish this segment off before we continue on. So any questions about ST segment elevations before I continue? None. All right. So what is, when we talk about depressions, it can be considered a normal variant. So just because someone has ST depressions, I know we've been trained to say, okay, there's clearly some ischemia going on, but just know that it's not always the case. Pseudo ST depression can be seen if the patient, maybe they have a lot of hair, or they're sweating because they're nervous, and electrodes aren't able to clearly attach to the skin. So it can create the appearance of an ST segment depression because the electrical activity is not going through it as well. Maybe if there's a J point change, which can be physiologic, which we talked about the J point, that can cause ST depression as well, or even just hyperventilation, which I didn't know about. So your classic would be maybe an asthmatic, coming in with hyperventilation. And then when we see their respiratory rates start to normalize and their CO2 go up, that's when your sphincter should tighten because that person is puckering out and they're about to decompensate on you. So hyperventilation is something to just know of as a normal variant. But if we're going to focus on what are the things to be concerned about or to be more aware of for our boards and clinical settings, we're thinking about ischemic heart disease, right? That's what we get concerned about. Horizontal downsloping ST depression that's greater than 0.5. So we said the benign early repole was 1 millimeter or above as the benign early repole, but ST depressions are defined when they're less or greater than or equal to 0.5 at that J point. And again, in 2 contiguous leads. If you have it more than, while the greater than 1 millimeter is very specific, if you have greater than 2 millimeters in multiple leads, especially if they're contiguous leads, it's likely an NSTEMI. Okay, so just remember that the 3 lead rule, along with the change in 2 millimeters, is going to be increasing your suspicion for an NSTEMI. If it's upsloping, it's really not specific. So I think I have some, on this one, lead V4, it's somewhat of an upsloping ST depression. That's what we mean by the upsloping comment. But we can see that in someone that has sinus tach, as this person looks like they're running at about 150 beats per minute. Subendocardial ischemia, which might occur with myocarditis, can also cause ST depression, but you're going to see with widespread involvement. And again, don't forget AVR. Why do I mention that? Because it's kind of the ugly stepchild, or the one that we just never think about. But as Dr. Long kind of pointed out, he even mentioned the AVR when he was looking at that previous EKG. When you see ST elevation in the AVR with depression, otherwise, that's widespread, that's very consistent and specific for our left main occlusion, like that widowmaker we get worried about. That should be it. That's the most I want to talk about on that slide. So let's look at different types of these changes that I kind of referred to, because just going through this text doesn't mean anything, to be honest with you. I learned from images. So let's look at this specifically. So what does the normal EKG look like? Well, here's a normal EKG. We don't see much ST depression. Remember that 0.5 or more is what we're looking at. If we get to 1 millimeter or more, it's very specific. 2 or more in 3 leads is very concerning for an NSTEMI. If we did an upsloping, so you can see how this segment is not completely flat, it's starting to go upward. That's the upsloping that I was telling you about. A horizontal is clearly just exactly flat. And then a downsloping is exactly what I just talked about. It's just kind of moving in the opposite direction of an upsloping. And here are some drawings with lines I kind of put through to kind of show you exactly what we're talking about. So when you see this horizontal, that's very concerning, as well as the upsloping is not very specific. So if you see an upsloping ST segment depression, not as concerning, but a downsloping and a horizontal should be something that piques your interest, especially if it's in multiple leads that are contiguous. So let's look at that left main occlusion that I just told you about, where we try not to avoid the appearance of AVR. Again, I'm not having you guys individually or called out to read EKGs. I think I talked about it on the first part, but I just never liked it when I was a resident, and it always put me on this you get a little tachycardia yourself when you're having to read an EKG in front of your classmates. But when you rotate with me on hospital medicine, I will be asking you guys to read this in front of the team. So we look at the left, or AVR, we can see some elevation in AVR. We see some reciprocal depression, looks like in 2, 3 AVF, not as much in 2, but definitely in 3, or in 3, I mean. But in lead 2, if we were to draw a horizontal line across, we can see that it appears to be at least greater than 1 millimeter or more, as well as here in AVF. And then we see more depressions that I marked with the purple arrows in 3 all the way through 6. So when you see this AVR elevation with reciprocal depressions in 3 or more leads, but especially in that lateral, that's more consistent with the left main occlusion. Let's look at the high lateral STEMI. So the high lateral, remember, is 1 in AVL. The low laterals are 5 and 6. So if we saw elevation, if you said maybe you don't see the elevation first, maybe you're looking and you see the depressions first. So we look at 2, 3 and AVF and we see, okay, there's some depressions in 2, 3 and AVF. And we start looking around. V3 still depressed, maybe in V2 as well, not much in V1. In V4, we see it, maybe a little in 5, not much in 6. But like, okay, where's the elevation? We look at R because we don't want to forget that. We don't see it, but we would be more suggestive of left main disease if we saw it in V4, 5, and 6. So we look at 1 in AVL. Now we can see that there's some elevation in 1 in AVL with reciprocal depression in 2, 3 AVF. So this is more suggestive of a high lateral STEMI. All right. So that is all the ST segments. Went through a lot. We went through QT as well. Talked about how to calculate very quickly, rudimentary as well as maybe somewhat more of a mathematical way, how to figure out your QT prolongation. Then we went to ST segments, talking about benign early repolarization, went through both elevations and depressions, and how to decide if something is not as much of a concern, like it's an upsloping versus a downsloping or horizontal ST segment, as well as elevations, the tombstone versus the happy face, concave versus convex, respectively. What questions do you guys have before I try and go into, let me see. So we are on slide 122, it looks like. Oh no, 173 of 137. So I should be able to finish this off in the next one. Do you guys want me to start on T waves now, or do you want to stop here? UAA means nothing. Stop codon. Oh, that is so lame. I'm glad I actually got that recorded. I cannot believe, oh my gosh. Okay. Mafoos. All right. Yeah. Big nerd. All right. So we are going to stop there, and then I will put a marker that this will be the start of part 4. I think I'm talking again tomorrow on the 21st. Yep. That's going to be a fun talk. We're going to go over perioperative evaluations because last year, I don't think you guys ever had a talk on that. So I developed one. And then the next time I will talk will actually be on the 28th. Then we're going to get into vasculitis. I don't like vasculitis. I think vasculitis is interesting, but it's very hard. So it's going to be split up into 2 different sections. And then I think Dr. Joubert is out, so that I will be talking on Monday. I'm going to either do I'll try and finish up EKGs, but I do have a talk on antibodies that I developed for you guys last week because it was something that I wanted to learn more about, and going over the fluorescent patterns when you're looking at ANAs and what does it mean for it to be a homogeneous versus peripheral versus centriolar versus nuclear versus that's pretty much it. Pattern. So we're going to go into just those. It's kind of a rundown talk, but it's enough. I don't want to go too much into specific autoimmune conditions, but I did develop a PowerPoint and discussion on that because I think it'll be kind of interesting from a room perspective during that block. All right. Any questions before I close our Zoom? Anyone other than Mafoos? All right, Mafoos, what question do you have? Even though I don't think you have a question. 3 seconds. 3, 2, 1. Batman. Oh my gosh. Okay. I wish I could have the last 10 seconds of my life back. All right. Thank you all for paying attention.